Good afternoon, everyone, and welcome to today's webinar on supporting your collaborative when planning for safe care for infants with prenatal substance exposure, presented by the National Center on Substance Abuse and Child Welfare. Today's live discussion is brought to you by the National Center on Substance Abuse and Child Welfare, an initiative that is co-funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA, Center for Substance Abuse Treatment, and the Children's Bureau at the Administration for Children, Youth, and Families. My name is Jean Blankenship, and I'm a Child Welfare Program Specialist for the Office on Child Abuse and Neglect at the Children's Bureau. Our discussion today is facilitated by Jill Gresham, the Senior Program Associate for the National Center. Today, we are also joined by Trenny Parker, Director for the Division of Family Services within the Department of Services for Children, Youth, and their Families in Delaware, and Jen Donahue, Child Abuse Investigation Coordinator for the Office of the Child Advocate, also in Delaware. We're also joined by Monica Taylor, Chemical Dependence Director for the Crouse Health in New York, and Susan Morris, Substance Exposed Newborn Specialist for the Child Protection Services Unit in Colorado. Today's discussion will focus on the experiences and knowledge these presenters have for serving pregnant and parenting women with opioid and other substance use disorders in their states. Jill Gresham will be fielding questions to the presenters on additional topics, including treatment needs for pregnant and parenting women and their elements of family-centered treatment, the effects of substance use exposure to infants and treatment needs for infants with neonatal abstinence syndrome, the importance of collaboration when supporting parents' treatment and recovery, plans of safe care, and a discussion of challenges experienced by partnerships in these states. You will be able to type a question into the questions feature on your screen during today's discussion. A picture of the questions box is on the slide below. There will also be a time set aside toward the end of the webinar to address your questions. If we don't get to all of the questions today, and we certainly will try to do so, we will work with the National Center to make sure we get responses to folks after the webinar today. With that, let's get started, and I'm going to turn it over to Jill.
Thanks so much, Jean, and welcome, everybody. So before we jump into our panelists today, I just wanted to do a really quick overview of the changes to the Child Abuse Prevention and Treatment Act, which were held within CARA, the Comprehensive Addiction and Recovery Act. So many of you, when we think about the Child Protection and Treatment and Recovery Act, sorry, slides are jumping forward on me. It's a really large piece of legislation. It dates all the way back to 1974. We're really talking about a small piece of it that specifically addresses infants with prenatal substance exposure. This language first appears in 2003. We see a small update to it in 2010, and then a larger update that happens in 2016. I want to talk a little bit about some of the changes that took place in 2016 because really they gave states a lot of flexibility in terms of determining how to implement plans of safe care within their state. And today we're going to hear from 3 states who have taken 3 very different routes towards implementation to give you all an idea of what it could look like. I think the big piece with the change in CAPTA was there was the striking of the word illegal. So prior to 2016, infants who needed a plan of safe care were defined as those born with and affected by substance abuse or withdrawal symptoms. Pardon me, previously it said born with and affected by illegal substance abuse or withdrawal symptoms resulting from prenatal drug exposure or FASD. When they struck that word illegal, it did open it up to infants who had been born exposed to different kinds of prescribed medications. The language in CAPTA doesn't actually really further define what it means to be affected by substance abuse, and so that's one area where states had to come together and make some decisions. The CAPTA legislation also increased the data that was required to be reported up to the federal government from the states. And then again, it actually expanded who needed that plan of safe care. So previously, that plan of safe care was really focused on the needs of the infant. In 2016, that was expanded to include not just the infant, but that primary caregiver and family members. And then finally, it actually increased the monitoring of plans of safe care to ensure that the families have access to those services which were contained within the plan. One of the other pieces around CAPTA, although it does mention the plan of safe care and meeting the needs of that infant and that family member, it doesn't really go much further in terms of fleshing out what it could look like. And so this is, again, another big opportunity for states to make some decisions about really what is a plan of safe care. A plan of safe care does, in our thought, go beyond a safety plan, because again, we're thinking of not only the safety of the infant, but also what's happening with that caregiver. It's again beyond what a substance use disorder treatment plan is, which usually focuses on that mom or that dad's treatment needs, and it includes what's going on with that child, so maybe those developmental needs, as well as perhaps some safety needs. And then again, you'll see it goes beyond sort of a hospital discharge plan, which would be primarily focused on the health of those family members. What you see on the screen here is really, at the National Center, we kind of came together and thought, if we were going to put together a plan of safe care, what elements could it include? And so there's not a have to here, but this is just, the potential of the elements that a plan of safe care could include. And you can see there's health needs for that infant, and there's mom's medical care, dad's medical care, there's substance use and mental health needs. And so if you get a sense that plan of safe care really is sort of a family wellness plan, right, for that child and that family for wellness. So again, beyond sort of that safety plan that we think of when we think of care plans within the child welfare world. So CAPTA also doesn't tell us exactly who needs to oversee that plans of safe care. Again, we see lots of opportunity for states to make some decisions about who holds those plans. And we're going to hear today from each of our presenters different models for holding that plan of safe care, as well as what those plans of safe care address. And so I'm going to turn over to our presenters now. Again, please feel free to drop questions in that question box so that we can get to those today as well. But I'm going to start actually with our team from Delaware, with Jen and Trenny. Why do you do this work?
So I've spent my entire career working in child welfare and became engaged, specifically working with infants with prenatal substance exposure, more closely around the enactment of CARA. So I think while all jurisdictions, I'm sure, were very apprehensive about this legislation passing, we tried to take an opportunity to look at different ways to engage families in this work. So Jill, some of the things that you highlighted about plans of safe care as far as collaboration and working with others in the community is something we really tried to move forward. So it's really been something that I've worked on for the last couple of years, and hope to continue to make progress with what we're doing here in Delaware.
And Chenny and I have been collaborating. We're in different agencies. I'm with the Office of the Child Advocate, and she's with Child Protection. We've been collaborating for the past several years around this issue. Initially, my role in the Office of the Child Advocate was and is to monitor and track serious injury, death, and other cases against children. And in my collection of those cases and those case data, it was probably back in 2014. That we determined that there were some, the infants with prenatal substance exposure was a real issue in our state, and we were seeing some negative outcomes. So in 2015 is when we really started collaborating together and developed a committee to try to tackle these issues as a team.
Sorry, I was on mute. Susie in Colorado, how about you?
Yes, I've actually been here with the Division of Child Welfare for almost 2 years, and actually this new position that I'm in as a substance exposed newborn specialist is a brand new position, and so for me, when this job came open, it was a huge opportunity for me to echoing a lot of the same sentiments that were mentioned is that there's this huge opportunity within our community to work collaboratively and to kind of get ahead and working more effectively with families. And as far as the child welfare perspective is that, yes, we very much want to work with families. We do not want this to be a scary process. We certainly don't want families to be afraid of losing their babies. And we really want to rally around families, engaging them in this process and offering them the supportive services that they need from hospital all the way through child welfare, and even when they're done and moving into the community with those supportive services.
Thanks so much, Susie. And how about in New York, and Monica?
Good morning and good afternoon. So I oversee addiction treatment services at Krause Health in Syracuse, and we are also operating an opioid treatment program. And one of the things that we have seen as a result of the opioid epidemic was a tremendous increase of pregnant women seeking services for their opioid use disorder. And at the same time, our NICU, which is part of our health system, the regional NICU, also saw a tremendous increase in babies born with NAS. So internally, we were looking at opportunities to serve this population better. And then a couple of years ago, we had the opportunity to be part of a pilot project here in New York State that was closely working with the Office of Addiction and Support Services, as well as Child Welfare Services and DOH, to really take a look at how we can, here in New York State, improve access to services and support for this population.
I'd love to get a sense from each of you around what does the actual plan of safe care implementation look like in your state. You're all doing something pretty unique. So Susie, can you start us off in Colorado? What does that plan of safe care look like? So what populations are you, of infants are you working with, and who oversees the plan of safe care in your state?
So currently our rollout for the plan of safe care is very recent. And so we currently have our pilot county, or Larimer County is our pilot county, who basically volunteered to say, hey, we would love to try this plan of safe care. So up until this last year, we had a plan of safe care work group that worked very hard to come up with a plan of safe care. And then Larimer County, I think in June, began using this within their hospital. And from what I've learned, they've just recently, I think at the end of August, received their first plan of safe care. And right now, the feedback that I have received about who is actually completing it in the hospital has varied. So as they have actually rolled this out and tested it out, the feedback that the staff was giving was, again, they were a little stressed out and confused about who should be doing it. And so that could be the social worker, it could be the NICU nurse, it could be the bedside nurse. And what they found after they met and got to get some feedback about how this rollout was going, they decided that it would work best in their hospitals to have the bedside nurse be the one who would facilitate getting the plan of safe care and all of the information. So having one point person then going to all the different, the doctors of the different people to get the information, versus I think one of the challenges that they shared was if you're passing along the plan of safe care to all the different people who need to contribute in putting that information in, that was a bit cumbersome and things were getting kind of lost in the shuffle. So I think that they had felt it worked best for them to have the bedside nurse who's spending most of the time with mom and baby family to be completing it and getting the information.
Thanks. So interesting that Colorado is taking that tactic with the healthcare provider actually developing that initial plan of safe care.
Correct.
In Delaware, I know there's a multi-track system. Can you talk a little bit about what that looks like?
Sure. So in Delaware, one of the things that we recognized very early on was this was not something that could exclusively be managed by child welfare, which, speaking from child welfare, that was very beneficial to know that we were going to have collaboration from partners. So one of the things that we started with was the development of our actual plan of safe care form. That was a form that Jen and I created together, a committee of two. But we started to create 3 different pathways for how that was going to happen. So initially, the pathway that was most used and still is most widely used is that the Plan of Safe Care coordinator is the identified child welfare worker. So in our state, any infant that is born with prenatal exposure and a healthcare professional has determined that there are effects from that exposure that results in a notification to the child welfare hotline. Now, these cases they don't come to us for substantiation. They are risk of cases. So we're not looking at being punitive towards parents for this happening. But the Plan of Safe Care would be created and implemented by the child welfare worker and then followed after mom and baby leave the hospital. I emphasize mom, but of course this is a family-centered system, so other individuals who are involved are part of that planning process. What we started to realize is that some of our moms were already engaged in substance use treatment, and that connection to an MAT provider was one that was very strong for most of our moms. There could be peer recovery that was involved, so we started to work closely with our MAT providers, and so now they complete a prenatal Plan of Safe Care that follows mom to the hospital and could result in a notification to the child welfare system if there are other risk factors, but could also result in simply having the MAT provider continue to follow that Plan of Safe Care. Our last pathway that we have is we were fortunate enough to be able to create a contract for a differential response system that is provided to our moms who only have marijuana positive for their substance when the baby is born, and there are no other risk factors. So that contracted provider acts in lieu of child welfare. They complete the Plan of Safe Care, make decisions about what needs to move forward, and that's how we came up with the 3 pathways that we have in Delaware for our plans.
And as far as implementation goes, we began we only have 3 counties in Delaware, but we started small. We started in one of our birthing hospitals. We have 6. And then we slowly increased to the other 5 birthing hospitals. And we now have statewide implementation as of approximately 1 year ago.
Thank you. You mentioned the prenatal Plan of Safe Care, Jenny.
Yes.
Just wanted to point out that a prenatal Plan of Safe Care is not something that's required by that federal mandate. But my guess is that if you know this infant is coming, right? If we know that mom is on methadone or Suboxone, it makes sense to develop that Plan of Safe Care, and then that gets handed off, right? After the birth.
Yes.
Great. Thank you. How about in New York? What does it look like in New York, Monica?
So we're still somewhat in our infant stages here, but ultimately, I think maybe we can divide it into pathways. So if an infant with substance exposure is born and there are child protection concerns, the hospital will still make the hotline report. And in that case, it would really be child welfare who will be responsible for the development of the Plan of Safe Care. Then there's the other group of individuals where the infant is also born showing substance exposure, but maybe mom is on MAT, or maybe she is under the care of a physician for maybe pain management and is on medication that might cause the positive or the substance exposure in the infant, or mom might be on benzodiazepines, maybe she's got a mental health disorder that is being managed, or she might be taking medical marijuana. And as a system, we continue to look at ways who best owns the development of the Plan of Safe Care. And, you know, especially with us being also an addiction treatment provider, we feel very strongly that we already have a relationship with the mom, and our counseling staff are really in the best position to start developing this Plan of Safe Care before the baby is born. Because in our Plan of Safe Care, the form that was developed by OCFS includes areas like basic needs, infant needs, you know, talking a little bit about what the mom's plan is in terms of the delivery of the baby, and then what kind of support services she needs after delivery. And I think, again, the counseling staff is in a much better position to start working out the details of this. And we found with our staff who now have done some Plan of Safe Care that moms actually really appreciate having this document. It's basically a 2-page document where they have resources written down for them and really can, I think they almost feel a little bit more at ease going into the hospital and deliver. And one of the things that we have also then decided in order to make sure this plan of safe care makes it to the hospital is that we obtain consent for release of information from mom to the birthing hospital and her OB provider. So in that way, if mom doesn't have the plan of safe care on her when it's time for delivery, we have the ability to send that plan of safe care ahead. Again, this is still in the early stages, and we're looking to expand this more. And what's helpful is that the Office of Addiction and Support Services here in New York State that certifies addiction treatment providers over the summer has published some guidance to treatment providers to really own this process for their pregnant women who might be on an MAT.
Also feels like a position of strength, very strength-based for a mom to come in with that plan to that birthing hospital and say, this is what I've been doing, this is what my treatment looks like, right? Really nice practice. I see there's a question coming in actually for you, Susie, in Colorado, around after that plan of safe care gets created by that nurse, and it's actually a little bit cut off. I can't quite read the bottom, but I think it's asking, does the nurse always send that plan of safe care to child welfare? And I think it's sort of a broader question. Are there families that get a plan of safe care but don't actually require child welfare involvement?
Yeah, great question. And I think these are some of the things that we are still trying to work out. Ideally, we would like mom to leave the hospital with her plan of safe care. One, so that she is taking it to all of her providers and there's continuity and consistency with her care. And then when, as it relates to child welfare, one of the things that we are trying to build into our hotline is that when a call comes in, actually we've done some work, we've actually entered in some questions already related to the plan of safe care and substance exposed newborn. So the call taker will be prompted to ask those questions, and then they will also be asking, do you have a plan of safe care? So if the person calling in identifies that the baby was substance exposed, then they will be asking, do they have a plan of safe care? If they do, we are hoping to be able to upload those and attach those to that case. So again, it follows through. Our backup plan to that, in the case that either, a plan of safe care hasn't been completed yet, or there isn't one, we are looking at building in a plan of safe care in our assessment process. So if they say, no, we don't have a plan of safe care, but yes, there's the newborn was substance exposed, then they will then create a plan of safe care as part of the assessment.
All of you have mentioned some kind of group that came together, a collaborative at the beginning, some kind of teaming. Can you, maybe we'll start in Delaware, can you guys talk a little bit about who are the primary partners, who has to be at the table to do this work?
So we started this work actually out of our citizen review panel, which is the Child Protection Accountability Commission. So a subcommittee was created around substance exposed infants. That's what we called the group. Jen is the co-chair of that group, along with a local pediatrician, Dr. Alan DeYoung, who's with AI DuPont Nemours. So in bringing that group together, child welfare was at the table, our public health systems, substance use disorder treatment providers, birthing hospitals, other individuals that are in healthcare that support programs like home visiting and WIC. It was really a large group of folks that came together to start this work. And then quite honestly, we were extremely fortunate to work with Jill and her colleagues around having in-depth technical assistance that helped us further solidify the work that we were doing. It was a smaller core group of a team that worked together, but really helped us to move this to a different stage. It was extremely beneficial to help our work.
I've worked with a number of states, especially around starting to draft some of those definitions for what does it really mean for an infant to be affected by. So important to have doctors on that committee, folks from healthcare to help you draft those definitions. You don't want to get down the line 6 months or a year and then kind of hit a brick wall around some resistance. So get those voices at the table, have child welfare there, have the medical establishment, have treatment there, so that you can all come to that consensus this definition. You know, I often hear also that it can be really difficult to engage MAT providers to be a part of those collaboratives. Sometimes, you know, especially in states where it's a fee-for-service model, if those providers, like, you know, it's billable time that they're missing, it's hard to come to meetings. Monica, as an MAT provider, can you talk a little bit about how, kind of what was the carrot to get you guys to the table, and how folks might think through engaging MAT providers in their states?
So we actually happen to be a lead organization in the effort. I mean, to me, this made so much sense because, again, I think women face so many barriers, and especially pregnant women who are actively using substances, they deal with a lot of stigma and tend to be late care seekers. So for us, it made so much sense to be partners in this initiative, because when we think of our services, of our opioid treatment program, I mean, this is not just giving somebody a medication to assist their recovery efforts. It's really, I mean, it's a comprehensive treatment that addresses all kinds of areas that the woman might be dealing with. So for us, that made perfect sense. And then I guess being in this unique position where we also are a birthing hospital and have a large NICU for our region, it really gave us a great opportunity to start internally to look at a plan. Okay, how can we, even with our own patients, with our patients who are in our opioid treatment program, how can we have better communication between the NICU or the labor and delivery staff to make this a better experience for the women? And a lot of education had to go into the language that we are using, because again, a lot of our women, you know, would report back to us after their birthing experience how they did feel, you know, that they were treated differently. And I feel like we've come a long way with providing providers with education, bedside nurses with education, and I think that's such a key piece in an initiative like this to be successful. And from my experience, other MAT providers, especially those that are running certified substance use treatment agencies, I think they would welcome this opportunity for collaboration because it makes the most sense for the women that we treat.
You mentioned a bit about kind of that stigma that pregnant women face if they're struggling with substance use. I think that intensifies in some states where abuse or neglect or use during pregnancy is like codified as abuse or neglect. I know, Susie, that's something that Colorado deals with. Can you talk a little bit about that in Colorado and how what work you've done to engage pregnant women, knowing that law is in place?
You're talking about our children's code that basically states that if a newborn baby has tested positive for a Scheduled 1 or 2 substance, it's automatically considered abuse and neglect in our state, which creates a lot of barriers. And this is an area that we really truly are trying to address because it does impact how some of our states are choosing to, or how counties are choosing to perhaps approach our child welfare practice. And so I think you're alluding to our 2 tracks. Is that what you wanted me to talk about, the DR versus our traditional track?
Yeah.
Yeah. So yes. So right now, our because we are state supervised and county administered, as it relates to our child welfare practice, our counties have the ability to follow the differential response model or our traditional. Currently, I would say the majority of our counties in our state are following the DR model, and we have even more who are in the process. So I think at the end of this year, the majority of our state will be following this model. But when a referral comes in, if it is a DR county, they may do the assessment, and they may find that there is no finding. So there is a concern. They do the assessment, and they do not come up with a neglect or abuse finding. And so a lot of, so those services then become voluntary. We offer families services at this point, and our focus really truly is to engage families, rally up supports around them. We do have, however, as you mentioned, in our other some of our other counties, where that is not necessarily the case, and so they may be more inclined to do just as our Children's Code states and place a finding because of this. And so the outcome may be the same. They may still choose to provide services. Doesn't necessarily mean that it's a court-involved case or that we will necessarily open a case. However, again, yes, unless there's that finding, then that creates that discrepancy in care from one county to the next.
Yeah, and I think that's why I've heard all of you kind of talking about that prenatal period and trying to get upstream to identify substance use during pregnancy to engage moms as much as possible in treatment. Can the Delaware team, can you guys talk a little bit about your work to identify substance use during pregnancy and support women and roll that plan of safe care out?
Can I go ahead?
Sure. Well, initially, through our Substance Exposed Infants Committee, we worked with public health to create some materials that were targeted to our OBGYNs. It's helpishere.de.com, and it is materials that it's sort of training materials, informational materials for the OBGYNs to learn how to identify, learn how to provide different screenings to pregnant women who may be suffering from a substance use disorder, not for the purposes, not for any punitive purposes, but in order to then link those women to services prenatally. There has been a few challenges trying to reach the OBGYNs in our state. However, Trenny has identified within DFS, within our CPS, an actual unit that is specifically handling infants with prenatal substance exposure. And Trenny has had her workers reach out to, at the prenatal stage, reach out to some of the substance use disorder treatment facilities, such as our MAT providers, in order to engage those moms early on, to try to reduce the stigma, to try to explain to these moms who may be suffering, these pregnant moms who may be suffering from a substance use disorder, that the Plan of Safe Care in Delaware is a supportive document and is thankfully under our law, exposure is not under the definition of abuse or neglect. Thereby, we reassure these moms get prenatal care. There will be a notification to child welfare, but it doesn't mean that there will be a substantiation. So we try to, early on as possible, we try to support the moms, and hopefully the public health materials have been helpful for the OBGYNs to link those moms to services.
Monica, do you want to talk a little bit about the ACOG bundle that came out of New York?
Sure. So here in New York State, we have a project called the Opioid Use Disorder in Pregnancy and Neonatal Abstinence Project. And this was started in November of 2018. And ultimately, it seeks to identify and manage women with opioid use disorders during pregnancy and improve the identification and standardization of therapy. And so AIM, which is the Alliance for Innovation on Maternal Health, of which ACOG is ultimately a leading partner, has developed several safety bundles, but one specifically deals with women with opioid use disorders during pregnancy. And it is really a great resource, because ultimately what it is it provides some a structured set of evidence-based practices, and they really can help improve patient outcomes. And it's not really that it's new guidelines, it's ultimately organizing all the existing guidelines and really put them together in a format that can aid practices in better treating the population. And I think what's also really exciting about the material is that it does allow for customization. It's not like this very prescriptive set of guidelines, because I think we have to recognize that each community is so different in terms of the resources. So I think it is important that there is an opportunity for communities to look at what their existing resources are and then utilize those in order to, guide their practices.
Thanks, Monica. I'm getting a couple of process questions coming in. One is for each of you, if you have a plan of safe care for a family that's not involved in child welfare, who oversees that plan of safe care? So I'll start with Delaware.
So for us, it would either be the MAT provider or our contracted provider. So our ask of each of those entities, it's much easier, obviously, with our contracted provider because we have a contract with them that outlines what is needed. But our request is simply that they share aggregate data with us so that we can have information on how many plans of safe care were completed outside of child welfare.
And then how about in Colorado, Susie, who oversees the plan of safe care for non-child welfare families?
Yeah, so that is still something that I think we're still trying to figure out as to where that will land. Again, that's going to be following mom, but as far as where that, like who's going to be collecting any data or where that might land and who will be responsible, we haven't quite figured that out.
Okay.
Yeah, and so it definitely, at this point, it's just going to simply follow mom, hopefully in her hand, and then to her primary care doctor.
And how about in New York, Monica?
And I think it's similar here, where we still haven't figured out all the details yet. I mean, especially for us, it makes sense. I mean, as an MAT provider, where we do work with our women long term, it makes sense for us to be the ones monitoring it. But we don't really have any processes in place at this time where there is any reporting back to any state agency or county agency in terms of, how many plans are completed, what kind of compliance there is, or things of that nature. So that, I think, is still something we'll have to continue to see how that develops. And I also know, I mean, the women do have an option to also decline the development of the plan of safe care. I mean, at this point, that is a voluntary piece. So I'm not quite sure yet what, in terms of reporting requirements on those, what that's going to look like long term.
Okay. The other question coming in is specifically around information sharing, so I'd like to kind of shift that conversation. So we've talked about the plan of safe care. There's multiple partners who are engaged with this family. Really, the purpose of the plan of safe care is to bridge those gaps, right, to create collaboration. So can you talk a little bit about the process? How do you share the plan? How do you deal with that 42 CFR confidentiality around substance abuse and also HIPAA regulations? Monica, you want to start us off?
Sure. Ultimately, of course, it is the mom's plan of safe care, and in theory, she has a copy of it and brings it to all of her providers. But as we know, that probably is not very realistic that will happen. So what we have done ultimately to allow us to communicate is get those consents signed at the same time as we develop the plan of safe care. Because otherwise, if mom ends up in the birthing hospital, wherever she delivers, and we don't have that consent, we can't really share it with that hospital unless she signs a release at the hospital. In particular, for our patients with substance use disorders, 42 CFR Part 2 is so much stricter than HIPAA requirements are. So what I would suggest is, for substance use providers, be proactive and get the appropriate releases ahead of time so that you can share this at the time of the birth. And then I think what might also work for some communities is to have some kind of MOU in place that would allow this kind of sharing of information. So that could potentially work as well.
Would you add anything, Trini or Jen in Delaware? I know you've been sharing these for a while.
What we have incorporated into our plan of safe care is the actual authorization consent that mom agrees to allowing the plan of safe care coordinator to share the actual document with all of the plan participants. And so mother is part and the family is part of the creation of the plan, and they identify the plan participants, which would be the pediatrician for the child, would be mom's substance use disorder treatment provider, anyone that mom is going to be getting services from. So at the end of the plan of safe care, the plan of safe care coordinator will go through both the HIPAA and the 42 CFR, 42 or 46, and explain to her that this is going to be shared with her consent. And the plan of safe care coordinator will share the document within 48 hours after the discharge meeting. That's usually done the old-fashioned way of scanning and emailing it to the pediatrician and other plan participants. But again, it's done with mother's consent and informed consent. And if she does not agree to certain plan participants getting a copy of it, then of course we'll abide by her wishes.
There's a question coming in about the voluntary nature, and I think this was directed at you, Susie, around the sort of differential response track for some of these infants. I also know that in Delaware, for those lower risk cases that have the external contractor, those are voluntary as well, if I'm correct. So the question was, how do you ensure the safety of an infant if those services are voluntary? So can you talk a little bit about the safety assessment piece and how you might come back around? I'll start with you, Susie.
Yeah, so in our state, we have the Colorado Family Safety Assessment Tool. So regardless if it's a FAR county or not, this safety assessment tool needs to be completed at the time of assessment. And so our safety assessment basically addresses like 10 areas of potential concern. So we're taking a look at those areas and doing a thorough assessment. So we're not just addressing, for example, the substance exposure, right, or the concerns, the safety concerns on that. We're also looking at the bigger picture. And so we're looking at all 10 of those areas. And in order for us to reach current impending danger on that list, to get to a yes, it needs to reach all 5 threshold criteria. So this tool basically was created in our state to offer consistency through our assessment process and assessing for safety. So this tool is done and upfront. If there are no safety concerns that are reached, there's no current and impending danger, that is when there would be they would reach a decision that there's no current safety concerns, and so therefore offering services to families.
Yeah. In Delaware, you guys use a contracted provider. Is there anything different that happens there?
So with the contracted provider, that assessment by the contracted provider is voluntary. Now, if the family says, I don't want to work with the contracted provider, then the notification returns to child welfare, and we would take over as the plan of safe care coordinator and doing the assessment for the family. Because the thing that I want to stress is the voluntary piece of this is completion of the plan of safe care, not the assessment. I don't want to use investigation because that gets into, substantiation, but the assessment that's completed either by child welfare or by the contracted provider.
So Jen, you had some interesting data that you shared with me last week around the type of substance involved and safety. Can you talk a little bit about that?
Sure. In Delaware, we have been collecting data on infants with prenatal substance exposure formally since 2015. So my office maintains a separate database utilizing the data from Treni's child welfare system. And we track different points of interest, important areas such as the type of substance exposure. We also look at, of course, the birthing hospital, whether the mother has a prior substance exposed infant. We also look at whether there's a child abuse or neglect to this particular infant after the infant has gone home. We look at whether mother has her own history of abuse as a child, whether the mother also has a mental health condition. So we're taking all of our data, and we are trying to determine, some risk factors or areas where we need further intervention. We're looking at age ranges of moms and tracking those over time. If there, for instance, if there are a group of moms that are, between the ages of 14 and 17, we know that we have to focus our intervention services to the younger crowds, to high school. What we've done with our data is we have partnered with our children's hospital, AI DuPont, and we have provided them with de-identified data, and they are looking at exactly what can this data tell us as far as whether there would be risk factors to determine if a child's going to be abused or neglected based upon exposure. And really what the study has shown is that it doesn't really matter what type of substance that the mother is utilizing during the pregnancy. It's the social factors that go along with it. It's the substance use in and of itself along with the social factors. So we have seen negative outcomes with infants who are just exposed to marijuana. We have seen negative outcomes with infants that are exposed to other drugs such as opiates. So what we try to do is not just look at substance, the type of substance. We want to look at the whole picture and the totality of the circumstances of that particular mom and family. And so we're continuing to collect our data. It's very informative. It's what I would actually encourage other states to do. If you can, try to identify, because it also gives us just a better look at where we can focus our attention and services on the moms.
Thank you. So we have a question that's coming in that's around disproportionality. I know that we've talked a lot when we think about the ACOG recommendations around universal screening. One of the reasons around universal screening is to prevent some of that disproportionality. Any of you have a sense of how are you addressing disproportionality with kind of rolling out these plans of safe care? Do you have a sense that families might be disproportionately affected based on race or other factors? Can I start with you, Monica?
Sure. It's actually interesting. So when we started our work and we had put together a multidisciplinary group to start talking about how we would implement this here in our county, we actually had some people in the group that felt very strongly every woman should have a plan of safe care. This shouldn't just be geared towards women who, have a substance-exposed infant. And it was really more, the idea is, we're again singling this group out as being something different. And it is probably true that even women who give birth to a baby that is not substance exposed could really benefit from a plan of safe care, of having a plan of what kind of resources they have after birth. So I think it is really important as the plan of safe care is introduced to the moms that it is really being done with compassion and really being done from the perspective of, these are just some additional resources we can provide to you, not so much, because you had this baby that is substance exposed, that's why you have to do this. So I think it's going to be important as this is being rolled out in states and communities, how it is being introduced to the moms, because it can very much feel like we're singling them out again.
Susie, anything to add?
Nope.
Okay. In Delaware, I know you guys have done a good amount of work at that front end in terms of consistency around identification during pregnancy. Is it universal testing that happens? Can you talk a little bit about how you've worked with medical providers on that issue?
Yeah. So one of the things that really is a benefit for us is that each of our birthing hospitals, they have their own practice as far as screening, and it is universal. So they're not selecting any mom for testing based upon their concerns. It's universal testing. Now, one of the areas where we would still like to make some progress is that the number of substances on the panel be universal, but that's a work in progress. It's something that we're trying to engage with the birthing hospitals to understand that. But I think that it puts us in a really a better position to serve mothers who need services based upon their needs, not some some person's opinion. It's really based upon what we're seeing in the hospital. So to the extent that states are able to have those conversations with birthing hospitals to help inform those decisions, that's really crucial to this.
about the reporting prenatal exposure. So working with hospitals around who gets reported and developing consistency there.
Do you want me to address that, Jill? I'm sorry.
Yeah,
just want to make sure.
Please, Trini.
Okay.
Yeah.
Sure. So in Delaware, the prenatal exposure is really not something that becomes a notification to our hotline until the birthing event. So while we do have the pathway to do the prenatal work if a mom is engaged in MAT, the actual point of notification doesn't happen until that birthing event. Now, that said, one of the things that we are trying to do, as Jen mentioned earlier, is having our staff go to the MAT providers and talk to moms about what to expect, having conversations with the providers, with the birthing hospitals, so that everyone knows what to expect. One of the things that you had suggested earlier in the call, Jill, was what do you do to get people to the table to do this work? And I would say what we have done is we've taken the table to them. So while we have this great SEI committee that has all of this wonderful representation, that doesn't stop us from having meetings with the birthing hospitals, with MAT, with public health, so that everyone is informed, because our goal really is to make sure that moms have safe pregnancies, that babies are delivered healthy, and that they go home and they're safe. So us joining together as a collaborative has really been good to move that forward.
Thank you. A question just came in saying we've been talking quite a bit about parents, but how does that plan of safe care actually address the needs of the child? Susie, can you take that one?
Sure. So I think within our plan of safe care, there are some specific questions that are addressed about, especially as they're nearing discharge, about, mom's ability to care. And it might not be mom that the baby's leaving with. It could be a family member or another caregiver. So really focusing on, the ability for someone to be able to care, and the support systems leaving the hospital, with specific details around, scheduling appointments, for eating, especially if there are some withdrawal symptoms or specific care needs, that is part of the plan, and it's really specifying like who's going to be doing that and how the baby is going to get those needs met. Again, too, after care appointments. So we do have some built-in questions leading up to discharge.
And Monica, we've talked about the MAT providers, substance use providers, healthcare providers being a part of that plan of safe care team in New York. What child serving agencies are also a part of it? Do you have early intervention providers or other folks who are on that team?
Early intervention providers, certainly, and then through our county Department of Health, they offer multiple programs that are really geared towards both the pregnant woman, but also after the baby is born. So there's definitely an opportunity to connect the woman or the family with those services as well. And our plan of safe care is, I think very much strengths-based, where you start identifying the supports they already have and what kind of strengths the family has, that it really helps the family identify what their goals are. And then we look at, what services are they already getting? And then after birth, what kind of services do we think the family would benefit from? And then we would make appropriate referrals if possible before birth of the child.
Thank you. I'm going to switch and ask you all a final question before we kind of open it up, see if there's any last questions from the audience. What's your next step in your state for rolling out the plan of safe care? So can we start with Delaware?
You want to talk about that?
Yeah.
Okay.
So we have a couple of things that we're working on right now. I mean, our emphasis for this year really has been moving from the implementation to more of a monitoring phase. Now that we have implemented statewide, we want to make sure that we have good outcomes as we follow these families. The other thing that we are considering is a fourth pathway to serve moms. So one of the things that has come to our attention through our collaboration is there's concern about mothers who are on prescribed medications having kind of stigmatization because they are still requiring a plan of safe care if there's an effect to the newborn. So we have had some proposals about how to move that forward, and we're, again, working through the SEI committee to figure out what is the best pathway to move that forward. So we're hoping, probably not by the end of the year, but by next year, that we'll have something in place. And then we're just going to continue to work on things that we see as important to families, emphasizing safe sleep, emphasizing the importance of home visiting, and just trying to continue to work to keep children safe with their families.
Thanks, Brittany. How about in Colorado? I know you have that pilot going. What comes next?
Yeah, so we are in our, as you know, in our beginning stages of our implementation. And so we are actually gearing up to begin to roll out this to our other counties. And so we are actually planning a big kickoff in March to bring a lot of our hospitals to the table, and Division of Child Welfare, and some of our other key stakeholders to begin talking about the plans of safe care. And then in those next actually in this next year is our big focus, is to have the plans of safe care rolled out throughout the state.
Great. And Monica, in New York?
Similar to Colorado, I mean, we obviously are just right now wrapping up with the pilot counties, and so now I think the big next step is how is this going to be rolled out through the rest of the state. And you know, I know at this point the state agencies, Department of Health, and then the Office of Addiction and Support Services, as well as OCFS, are collaborating to really figure out how this can be rolled out, because you know, I think this brings up a lot of questions for a lot of systems, and even what we found with the pilot project. So our county participated, and then there was another county that participated. It looked completely different in the two counties, and it had to look different because the resources in each county were so different. And you know, in the other county, they had literally just one large OB provider, whereas in our county we have multiple OB providers, multiple birthing hospitals, so it just presents different challenges. So I think, you know, rolling this out statewide is a big undertaking, because you're dealing with so many variances from community to community, and I think it will just be important to continue to keep in mind that there is some flexibility on the county level to implement this.
Thank you, Monica. And thank you to all of the presenters today. Really three very different approaches to this plan of safe care implementation. We appreciate your forthrightness and talking through all these issues with us. With that, I'm going to turn it back over to Jean.
Thanks so much, Jill. This is going to conclude our live discussion for today. And I want to thank our presenters and the attendees for your time and attention this afternoon, really creating a robust conversation. Really appreciate the thoughtful questions that were presented. So thank you so much. For more information and to download any of the resources that were discussed today, or any of the additional resources that the National Center has on this topic, please visit the National Center website at NCSACW, or the acronym for National Center.samhsa.gov. In addition, to continue the discussion or ask any future questions, you can email the National Center at ncsacw@cffutures.org, or call the number on the slide below. All that information is down there below. We'd love to hear from you and help to carry out the vision and the mission of the National Center, and to help support communities improving the outcomes for children and families and in your communities. So thank you so much to everybody for your time today, and have a wonderful afternoon.